So good afternoon, everyone. If we can start filing in and taking our seats. The official timekeep, that is my iPhone, says that we are at 1 o'clock. So just give everyone a little bit here to get in. Okay, so if everyone can please make their way to their seats, and we will shut the doors to keep out the noise of those who are still networking. And I will, at this point, pass it off to Devin so that we can get our panel from WEDI and on stage 3 started. Thank you.
All right, welcome everybody. My name is Devin Jopp. I'm President and CEO of WEDI, and it's my pleasure today to moderate this panel regarding stage 3 meaningful use. We're joined by 4 esteemed panelists today. I'd like to briefly introduce them. Dr. David Chow is with Professor of Lab Medicine, University of Washington, and CTO of Information Technology Services, University of Washington Medicine. Dr. Chow has been on the faculty of the University of Washington since 1998 in the Department of Laboratory Medicine, where he's responsible for the clinical laboratory information systems. In 2005, he became CTO of University of Washington Medicine Services, the unit responsible for operating clinical and administrative systems for 2 academic hospitals, Harborview, UW Medical Centers, and a primary care network, UW Neighborhood Clinics, and 2 community hospitals, Northwest and Valley Medical Center. In addition to overseeing technical infrastructure, he co-chairs UW Medicine's Meaningful Use Committee and was responsible for coordinating MU activities in UW hospitals and its 3,000 practitioners. Linda Fischetti is Vice President of Care Delivery for Accountable Care Solutions at Aetna. Linda is the Vice President of Care Delivery within Accountable Care Solutions from Aetna and is responsible for designing and delivering high-value clinical solutions for accountable care relationships. These clinical solutions focus on partnering with health systems to improve the quality of health care and promoting cost-effective efficiencies in the overall provision of health care across all settings. Our third panelist is Shiv Gopalakrishnan, Vice President and General Manager of Health System Solutions with General Electric. Shiv brings a breadth and depth of healthcare knowledge to his role. He began his career at GE in 1999 with healthcare systems, magnetic resonance imaging business in Wisconsin, and serves in various engineering, product, and management roles in increasing responsibility. In 2009, he took over the role as CTO for Enterprise EMR business and subsequently promoted the role of Vice President and General Manager for that business. Currently, he is Vice President and General Manager for GE's Health System Solutions business, which encompasses a wide portfolio of products, including enterprise and ambulatory revenue cycle products and enterprise clinicals. And finally, we're joined by Rob Tennant, Senior Policy Advisor with the Medical Group Management Association. Rob is a Senior Policy Advisor for Medical Group Management Association, MGMA, and focuses on federal, legislative, and regulatory health information technology issues, including including HIPAA, electronic health records, electronic prescribing, and ICD-10. And as you can all tell, we kind of grab from various aspects of the healthcare system in order to make sure we have a really good cross-representation for this discussion regarding stage 3. We're going to do some prepared remarks first, and then we'll go ahead and do some questions next. But we've actually asked our panelists to address 2 things in their remarks with some of their slides. One is around kind of lessons learned around stage 1 and stage 2 for meaningful use, and the second is regarding thoughts regarding stage 3. After the presentations, then we'll go ahead and move into some Q&A as well. So with that, I'd like to turn it over to Dr. Chow. We'd like for you to begin, please.
Okay, thank you very much. I'd like to briefly introduce what the University of Washington is and just point out the fact is we're the only medical school in a 5-state area, affectionately known as WWAMI, Washington, Wyoming, Alaska, Montana, and Idaho, and that the hospital system, which is known as UW Health System, consists of the hospitals that Devin mentioned earlier and a few other institutions, including a primary care network. There are also some 20 other hospitals at which we are affiliated. And what makes UW Medicine somewhat unique is that in many ways it's a microcosm of healthcare across the United States, both from the standpoint of the healthcare system and from the standpoint of the information systems. For better or worse, UW Medicine, the core systems, we run 4 EMRs from 3 different vendors. For the inpatient side, we run the Cerner system for Harborview Medical Center, which is a public county hospital, and the University of Washington Medical Center, which is, of course, the Transplantation and Cancer Center. We run a Siemens Sorian for the inpatient in one of our community hospitals, Northwest Hospital, and we run the entire Epicare suite for Valley Medical Center, both inpatient, outpatient, and other things. On the outpatient side of all the other three hospitals, we're running the Epicare system. But one of the things that's gotten us in a little bit of a quandary is that we're running that right now. We're only 25% implemented in the academic medical centers, and to be completed in March of next year, May of next year. So of course, one of the things that's required for meeting meaningful use is getting all your systems implemented. There are a number of reasons for us being so slow in many ways. One of them is that we had a number of legacy systems which were placed in, which were running, and which people were very happy with, which were developed in-house. And many of these systems served essentially to act as a near medical record system, not necessarily at the levels at which we're expected today, but which the users were very, very happy with. The other thing that's changed over the last couple of years is that we've acquired a number of institutions, and the two community hospitals were not previously a part of our system, and we've gone into an integration mode, absorbing them. And of course, this occurred about the same time meaningful use started. Now, for us, the meaningful use started in approximately 2010. And we looked at, a few of us started looking at in the regulations that came out, and we're concerned about the complexity of the things we're seeing. But we didn't see anything in stage one that looked very hard to do. Were we surprised? The more we looked, the worse it got, and the more complicated it got. But you know, in the end, in retrospect, stage one was really pretty easy compared to the things we're trying to do now. The other thing that we observed very, very, very quickly was that we would not be able to do a big bang rollout because of the heterogeneity of our organization. We had some people on Epicare, which had been there since the beginning of, almost the beginning of Epicare. We're considered one of the early adopters of Epicare in 1996, 1997. But this was rolled out primarily in the primary care clinics. And this was a group that was very ready to go to stage one and even to stage two. But the rest of the organization, which had relied on its own self-built electronic medical record, was obviously not going to meet those targets. When we started looking at trying to get everybody onto the same level, we found a lot of things that we had to work on in stage one. One was to get the skill sets of the people up to the level that, I should be running the slides up. One was to get the skill sets of everyone into the level where we needed to be. And that was from a technical standpoint. What we had done on the Epicare system is we had built so many things that were not considered to be compatible with the current model of meaningful use that we really had to deinstall and reinstall parts of the software. And as anyone who's done the software realizes, this process actually takes longer than reinstalling the whole software from the ground up. In fact, Valley Medical Center, which started their install in around 2011, finished their install, were ready to go for meaningful use in 2012. While our primary care clinics, in order to get their installs retrofitted to fit the current software, actually took a longer time. Meantime, we did pretty well in getting 2012 and 2013. We've actually tested on the hospital side for both stage one. And all of us were very proud of what we had done until we started working on stage two. And stage two now has proven to be much more challenging, not only because of the individual issues that we came up with. Many of the targets didn't look too bad. The problems we started running into was when we started doing organizational issues. And many of the things like the direct protocol, which has been mentioned previously, required a lot of cooperation within the community. And the good news is in the Seattle area, the communications has been very, very good. The bad news is none of us could understand exactly what we needed to do as a community to really make things interoperate. In the end, basically what you're seeing is a vendor-specific model that seems to be occurring with the interchange of records. We still don't know how to do some of the stuff, like the direct model assumes that a provider is going to be communicating with a patient. The single provider, and I'll talk about this a little bit later too, the single provider, single patient model doesn't apply in healthcare. We have care teams. And the care team model means that my physician this week is not going to be my physician next week. The care team is responsible for the communications with the patient and so on. And the care team model means that the direct models as they stand up right now, at least from the vendors, haven't really fully addressed the model in a way that requires quite a few workarounds. The other thing we found in stage 2 is the code that's coming in is being updated very, very rapidly. In one case, we upgraded to the 2012 version of Epic, and we had something like a 60-day freeze. And during that 60-day freeze, we received 3 updates for meaningful use, for their updates to match the meaningful use changes or bugs, fixes, or whatever they had to do. Similarly, we had the same problem with Cerner. We were receiving updates almost on a weekly basis to either fix, address, or add features that were associated with the updates. Of course, as all of you know, in a complex environment like ours, these updates were very, very difficult to do because they required a lot of testing. And the fact is, by doing every week, doing updates effectively, you weren't doing much else. There was a lot of lack of clarity in the way the community was going to handle direct addresses. We were running around with models that Epic had developed and Cerner had developed, which were different. We had community models that were based around HIE, and all these had to be reconciled in a way that, in many ways, this was the most active part of the discussion in the community. There were weekly phone calls on that, and basically people were trying to still resolve those differences. The other thing is that as we went into a rolling attestation for our providers, we found that we basically have something like close to 3,000 providers. We had to build a whole database to track which physician was at what status and where they were and what they were attesting to. And most of the people, when ONC visited us something like 3 or 4 years ago, we were talking to the various people in the community. We probably have at least 3 to 4 times the number of providers that any other organization has in the Seattle areas, although the other areas are getting larger. And the entire model that CMS has is based on a single provider model. So basically, we're entering 3,000 entries into the CMS screens one at a time. And there's a lot of room there to make errors, a lot of room, a lot of data entry, and so we had basically 2 or 3 people looking at things. And you're supposed to do this all within a 30-day period right after you've done your attestations. When we start looking at stage 3, the issues, people ask me to comment on individual elements. The thing that really concerns us when we start really looking at stage 3 is not how each individual feature or checklist item needs to be addressed, whether it's medication reconciliation or whether it's communications with the Department of Health reporting and so on. It becomes the whole picture of trying to get the software in, get it from the vendor in a timely fashion, getting it implemented and tested, making the changes in the people and making them into a position where they would be adopted and hardwired. So our first reaction to that is that time is needed to really do this well. I would like to go through and talk about the key takeaways that we've learned from this thing. And there are 5 items here, and it's not quite following what's on the slides. The 5 things that I would say summarizes what we've learned about the meaningful use process is, first, is that both vendors and users need time to hardwire changes. We can make changes, but we can't make the changes that really are effective. One example I use is that our ophthalmologist, I'm a frequent flyer to our ophthalmologists, and they came on to our Epic system about 3 years ago. And I walked into a patient visit about a week after the Epic system went live, And he was having he was very slow. And he was fumbling around. His productivity was quite low. The last month or so, I went back, and the process had gotten quite good, and my doctor looked quite proficient, and it was very quick and almost as fast as he did. But that took 3 years to get there. In that process, I also noticed that the work now was divided between the ophthalmology tech, the front desk clerks, and so the balance of the work was shifted in some ways to make sure that the physician was back to his optimal efficiency, but this took 3 years to get there. And it took a fair amount of analysis and redoing of the systems. The second thing is the workflows that we've noticed are different for different systems. The Cerner workflow is quite different from the Epic workflow. In some cases, it may not be a problem. In other cases, it can be. Probably the most frequent thing we talk about in terms of causing problems has been the way the transition of care document works in each of those two systems. And the differences are large enough that they can be reconciled, but the fact is they're not addressed in the specification. When you find that you see this difference, you have to find a workaround. In our environment, complexity kills. That's factor number 3. Academic medical centers are complex. And by their very nature, this complexity becomes really a problem when you come to testing and try and do rapid implementations. To give you an idea, the number of order sets we have in our community hospitals is about 200. The number of order sets we have in our academic hospitals are about 800. And that means that we have a 4-fold number of things to test. The complexity kills also result in different workflows for our specialists, and I think that's been mentioned. Workflows are quite well tuned for their primary care. They're not tuned very well for the specialty care. The other thing, I talked about this earlier, item number 4, is that the care teams model that we use in healthcare consists of specialists. The reason why we do transplantation is because we have people who are very specialized in various areas. And the need for the specialist means that the care team behaves quite differently than the single practitioner. Communications with the care team is going to be quite different. The last thing is that the meaningful use has caused us to defer many activities which we would normally take in lieu because of resource, because of constraints of everything else. And they basically are items that really could have a severe impact on healthcare and the quality of care. And I think it becomes a trade-off of saying that should we not be deferring all these activities? They include replacing old systems, doing integration activities, revising, refining processes, and so on. But I think we should recognize that these activities probably have as much impact in healthcare as the meaningful use things, at least for us. Thank you.
Great. Thank you very much for your remarks. I do want to remind all of our panelists, please make sure you speak loudly and directly into the microphones. That will help for our audience online. I'd like to recognize Linda. Thank you very much for joining us.
Thank you. Thank you, Devin, for assembling such an interesting group here. I think that the audience is going to hear a number of different perspectives today and representing very different segments of industry. So my goal here is not to be proscriptive about timelines related to Meaningful Use 3 or to be proscriptive about the specifications of Meaningful Use 3, but instead I want to paint the historical picture of where we were when we first started talking about meaningful use. I remember sitting in Rob Kolodner's office there in the office of the National Coordinator, reading the legislation word by word by word and figuring out what is this going to mean to us in the future? How do we do this, and then how is it going to have impact on industry? And it's wonderful that we're at the point where we're actually able to see that some of that formative thought, and it's due to the people in the room, the people in the building, has actually created some significant advancements in health IT for this country. So I wanted to just sort of tell my story quickly and why am I working with and doing the work that I'm doing right now and telling the story that I'm telling today. And when I was first started, I'm a nurse. When I first started nursing in the late 80s, I thought, what is the most important thing that I can apply my time and my attention to? And at that point in time, it was HIV. So I spent the first 10 years of my career as a nurse for children with cancer and HIV. So in the late 90s, as I was going back to graduate school, I thought, what is the most important thing in healthcare that I now can put my time and attention to? And at that point, it was computerizing the healthcare segment. Remember when we used to call it computerizing the healthcare segment? And we knew that we could provide safer care and we could significantly increase our medical knowledge if we stopped writing on paper. And so I spent the next 12 years of my career working on that. About 3 years ago, again, I felt restless because the people in the room, the people in the building were fixing the significant health IT issues. So I thought, where do I need to now apply my time and attention? And that is improving the impact that the economic, improving the negative economic impact that healthcare has on our nation's economy. Our employers are not able to be competitive internationally, and a lot of this is due to the fact that healthcare is 30%. Launched High Tech, we've done a significant amount of work with adoption and getting information available and some information interoperable, but we're not quite where we need to be. So as I moved over to the payer side of industry, after over 2 decades in the provider side of industry, I was shocked to find out that when I looked around of where I can put my time and attention so that we can help providers not only survive the transformation that's coming as we move away from the fee-for-service model, but also to thrive as they come out the other side, improving quality, patient satisfaction, and the cost of care, I ended up in a payer environment. Entering into the payer environment, I was exposed to a new kind of caring, and this is the Aetna values wheel, and we take this wherever we go, and we always keep at the middle the people that we serve. But there are thousands of nurses right now that are calling patients who've been identified through risk stratification. Some of the risk stratification, as we heard from the first panel, is, we got a list of high-risk members, and because it was run off of claim data, it is so old that some of it was really irrelevant to the patient. But on the other hand, the predictive analysis that you can do when you have all of the information available to a patient. So for example, if you have an EHR install, you know everything about that patient within the EHR install. When they go on vacation, as one of the questions was about earlier this morning, or as they see they go to your competitor across the street to see a series of specialists over there, you lose all that information, but that full picture is available in the claims data. So we're able to run predictive algorithms to find people that are actually about to experience a risk to their health and their well-being. So with that, we have nurses right now that are calling people and saying, Linda, we see that this is what you clinically look like today. We really want you to consider enrolling in our outcomes-based clinical program so that we can help you better understand your disease and also help you feel empowered to manage your disease, which will improve your health outcomes as well as the outcomes of the population. And where we're working with accountable care organizations, we're able to then call the nurse coordinator at the accountable care organization and say, we've identified Linda and she's not engaging with us. Would you please pick up the phone and call her and then either engage her or refer her back to us? Or we engaged Linda, she's gone through our program, and we want to make sure that she sustains the goals, the health goals that she's achieved, and therefore we want you to be able to just provide reinforcement and follow up for this. So I've just given you a little story about how nurses today are doing this type of collaboration between what was previously a siloed payer and a siloed provider component of industry, both impacting the patient, but doing it from very different ways. Our opportunity today is to not only make sure that we leverage both of these talents, but also to make sure that we're doing it in a way that we don't have to have nurses calling each other, but we could actually take those data elements, patient name of program identified for, care coordination team on either the payer or the provider side, date of enrollment in that clinical program to improve the health outcomes, date of discharge from that clinical program, and move that back and forth so that the care provision on either the payer or the provider side is seamless. So we're going through our journey from meaningful use, and if we think about when we first started with this, we were really thinking about electronic health records and how do we install electronic health records in either a provider's office or a hospital office. And we knew that we were going to significantly improve the safety and quality of care when we did this implementation, and we've been stunningly successful at this. Now, all of a sudden, we move through this and we realize that with accountable care organizations coming online, and more importantly, providers interested in assuming risk for an entire population, that we have the need to do the care coordination across care management systems that are taking place. It might be the payer, it might be another entity that is contracted by an employer, or it might be at an ACO themselves. And so how do we all of a sudden think about interoperability is not just interoperability between electronic health record systems, but from the electronic health record system, the risk stratification systems, either doing the risk stratification or intaking the output of somebody else's risk stratification, or communicating around care management programs as well. So as we look on the left-hand side of the slide, we see the fee-for-service model, and we see that there's really not the need for that broad coordination of care. But as we move to the right side, when providers are increasingly taking on risk and are financially rewarded for proactively managing the clinical outcomes, cost, and quality for a given population, then all of a sudden they need to be able to answer questions that you can't answer out of just your electronic health record system. If you are just a provider-based ACO and you don't have access to the information that's stored within the hospitals around you, how will you be able to know whether you're decreasing lengths of stay, decreasing admits per thousand, and able to have some of those population level efficiency impacts? If you are a large clinically integrated network and you have, and you're working with the employer in your environment and you want to be able to show that you can provide differentiated care within your accountable care organization for that employer in your community, but yet you don't have the information that's available to, that has been stored in the EHR from the hospital across the city, then you really need to be able to rely on claims data to get some of that information in. Are you ready to take in the information from the claims data? So I would be remiss if I didn't call out the WEDI report that was published earlier this week, and there's a fabulous section in there around payment model changes and the 4 components of the payment model changes that are going to be considered as they move forward with their work. Connectivity, we've already talked about that. Eligibility and enrollment reconciliation, incredibly important when you talk about your dependence on claims data. Payment reconciliation, and then finally quality reporting and care coordination data exchange. And if you haven't had an opportunity to read this, there's a very well thought out framework and process by which this type of collaborative consensus decision body is going to move forward with this work. Of course, when you listen to the messages of the first panel that we had this morning, the priority becomes the quality reporting and the coordinating data exchange, and this needs to be what we put the majority of our attention and time to now. So the opportunity coming out of stage 1, stage 2 meaningful use is to really bring that floor up for everyone. Make sure that we have the foundations of information is not being put on paper, that we do have information collected in a way that it can be exchanged with others, and that we do have a level of saturation across the communities for this type of information capture. And then the opportunity as we move into meaningful use 3, of course, is to make sure that the EHRs are able to be aware of other systems that are required to meet some of the important business needs that are taking place in industry today. So finally, opportunities to support change. Of course, we need incentives. We need the payment model to change, both for those providers that are forward-leaning and out there assuming risk for populations today, as well as for interoperability. And then, of course, improving quality and accountability, supporting the National Quality Strategy aims for better better care, healthy people and communities, and affordable care, as well as the need for both early adopters and those that have been doing this for quite a while to both be successful in accomplishing the foundational goals of the beginning of the meaningful use historical timeline, and then I'll move forward with consensus when we are ready to move into meaningful use 3. So thank you.
All right. Thank you very much, Linda, for your great remarks. Shiv?
Great. Thank you, Linda. Thank you, David. I think you both did a fantastic job setting the discussion up here. And I've been part of GE Healthcare IT and really been engaged in stage 1, stage 2 meaningful use right from the get-go, understanding the requirements, really watching all the changes, the development, the certification, and eventually the rollout of stage 1 implementation through all our customer base. And I've got a few gray hair to show for that. So what I wanted to do is take a few minutes to kind of share with you my personal learnings coming out of stage 1 and stage 2, and I've tried to translate that into some recommendations, and I'm going to try to stay away from being very specific around the requirements, but more in general, what kind of things should be considered as we make this journey from stage 2 to stage 3. First and foremost, some lessons learned. I think we all would agree that stage 1 and then eventually stage 2, stage 1 in particular helped adoption tremendously. The hospital side, of course, but also on the provider side. And I think that's been great because it started to create an ecosystem where data is much more liquid and we can actually start sharing data in a much more meaningful way. And it hasn't been without a lot of blood, sweat, and tears from vendors like GE, from providers, several of you here, ONC and the CMS. All of the folks around have worked tremendously hard in making this a reality, and overall I think the questions that we've been bombarding ONC and CMS with, they've been very responsive, so we're very happy about that and we want to thank them for that. However, when you look at the broader landscape of things that are coming at us, and there's just a whole gamut of things we all have to worry about. ICD-10, that's impending here, accountable care. We've looked at implementing systems, but now it's time to look at usability and how do we make the efficiency really speak up here for our processes. Other ancillary systems that are sort of falling behind the cycle, and then of course any kind of state regulations that you need to keep up with. And quite frequently some of my provider partners, my customers, have termed this as the upgrade treadmill they've been on, and I think David reflected on that as well. So this has been a big challenge in some ways because of the consumption of the amount of software the vendors have to develop, but also the consumption of the software and implementation in a real meaningful way is quite challenging. So I think we need to kind of keep that broader perspective in mind. Having said that, meaningful use 1 and 2 so far has been quite a complex program. I mean, the kind of changes, the nuances that we've all seen come through in these programs has been very interesting and quite fascinating. But it's gone through a lot of iterations, and when you talk about what does it take to get the software built, installed, and being used in a care setting, if you focus on the upstream side of things, most of the development today happens as test-based development. So until you get the final test scripts and you really understand the requirements really well, our engineers aren't putting their hands on their keyboards and starting to develop stuff. And that really puts a big compression on the back cycle of what it takes to build the software, get it certified and installed across our installed base of customers. So I think one of the lessons learned has been that we really need a lot more time where we can actually build the software the right way, but we need all that information around, of course, the rules, but also the test scripts way ahead in the cycle. And the one other thing I wanted to kind of mention was, the way we grade stage 1 and stage 2, it's an all or nothing. It's like imagine you had just A and F grade in your school, and it's quite challenging. So it's important that we kind of think through that process as well and see if we can find a way to tweak that and not have an all or nothing situation. So as far as recommendations, I've tried to separate recommendations into 3 buckets. First and foremost, as far as timing and some general guidance from my point of view. The second bucket is around scope and how we should think about scope. And the third bucket is around certification and attestation. So those are the 3 categories of recommendations I have. And first and foremost, I think we need at least 3 years, maybe more, depending on the scope, but at least 3 years with minimal scope between stage 2 and stage 3 to make this real. But that doesn't mean that we wait for 3 years. I think we need intermediate milestones right now when we'll get information, requirements, test scripts, and what have you. And from personal experience, we need at least 18 months of time to get the product done and implemented at our customer sites. And that's I think one of the biggest concerns that we have as far as the development of these products are concerned. The second, as part of the scope, we've spent a lot of time putting in the software and getting the attestation done. I think we haven't really focused as much on getting the full value of these systems. So focusing on stage 1 and stage 2 and really making the functionality more robust, usability more robust, where you can extract the full value of stage 1 and stage 2 would be my recommendation to focus on, versus adding a ton of new requirements and measures in stage 3. Definitely, new requirements and new capabilities like, population health management, things like that. We want to make sure that we proved and tested it at certain locations across the country and seen how that goes before we start putting that into a requirement. We want to try to stay away from that as much as possible. As far as attestation, like I mentioned, trying to reconsider the all or nothing approach as far as what it takes to get it tested. Reconsider the three-month process, 3-month cycle for the stage 3. I think is going to be important as well, just giving the time for the provider organization to get up to speed and iron out all the kinks in the process. It's been quite promising to see some of the things come through as far as the consolidation of the measures is concerned, but I'm fearful that we're going to just put it into a bucket called it's just certification. It does put a lot of burden upstream in the process, which will get translated into timeline pressure for providers in the downstream. So I think we've got to be careful about that pitfall. And look, overall, there's just, like I said, there's a lot of conflicting, in some cases, potentially aligning quality programs out there, and I think it's going to be very important for us to look at this holistically for stage 3 and try to find a path that's much more meaningful in as far as usability and the implementability of the product is concerned. So those are my high-level points, and I'd like to pass it on to Rob.
Great. Thank you, Shiv. Rob?
Great. Well, appreciate being here, and Devin, thanks so much for the invitation. When Devin approached me to give the physician practice perspective on meaningful use, he asked me, how long would I need? And I said, between 8 and 10 hours with perhaps a 5-minute break. And he said, that's wonderful, you have 10 minutes. So I'm going to give a very high-level overview of what I've been hearing from our members. And our members are practice professionals. We have about 30,000. And they range everything from very small single specialty groups all the way up to the largest multi-specialty medical groups in the country. And I think there are a lot of positives. And again, when you're last on the panel, there's obviously going to be a little overlap, but that's not necessarily a bad thing because you're going to hear themes. And one of the themes is this is a historic program. Many of you may have had the same thought that I had 5 or 10 years ago. What could we do with $1 billion in this industry? Well, we have $20 to $30 billion. So this is a historic opportunity. As Shiv said, we've seen a huge shift in the thinking of physicians. They do want to move to this technology. We're seeing some specialties at an 80% or more rate of adoption. So the incentives have clearly worked. And I think we've seen an unprecedented outreach effort by CMS. And certainly Rob Tegalikad has to be applauded, but his staff, Rob Anthony, Ethan Moore, have been incredibly responsive. If you go on the CMS website, there are literally hundreds of different resources available for providers to make these transitions. So really, hats off to CMS. But there are some concerns. And I think one of the things that we've heard as a theme throughout the day, and I think Rob Tegalikad did a great job of having a slide which outlines all of the things on CMS's plate for 2014. Well, guess what? They're on the plates of providers as well. So we've got Health Insurance Exchange, ICD-10, the Admin SIMP provisions of ACA, Payer ID, the new privacy requirements, SGR changes. Everything is happening at the same time. So meaningful use, stage 2, arrives in less than a month, and again, a huge opportunity, yet a huge challenge as well. We're concerned about some of the redundant requirements. For example, the security risk assessment, which is in there as one of the criteria, that's been required since 2005. So why are we putting extra reporting burdens on providers when that's already something required of them? And we're all familiar that meaningful use has been developed in a primary care-centric way. And I think a lot of specialists have concerns about the types of requests and requirements as part of meaningful use, and the fact that that's not necessarily part of their scope of work. As Shiv said, there's the all or nothing approach, which I think is a concern as well. Stage 1, perhaps not so much, but certainly stage 2 and stage 3, where the requirements become much more challenging. Having that all or nothing approach is going to leave a lot of EPs failing to meet the requirements. And all-year reporting, frankly, doesn't take into account the realities of practices. We're seeing somewhere around 17 to 20% of installs are being ripped and replaced, and it's impossible to go from one to the other with a flip of the switch. So there are downtimes, there are staffing issues, there are connectivity issues, there are occasionally vendor issues, and I think what we've called for in the past is a little bit of flexibility there. So rather than all year, perhaps allow some 10 or 20% of downtime. There's also a very interesting development with stage 2, and we've seen some of the criteria rely on actions that are beyond the control of the EP. For example, secure messaging and view, download, or transmit records via a portal. And that sounds fine, but when you look at the requirement that 5% of the patients actually have to do it, I think that's where we have some concerns. Having the technology is one thing, twisting the arm of the patient to actually use it is something else. And again, it's not out of the realm of possibilities that you will want to go on to the portal of your primary care physician, the physician you're seeing on an ongoing basis. But the chance of going onto a portal of a physician who you saw for 10 minutes in a consult is unlikely. Yet those are the specialists that are required to do exactly the same steps as the primary care. And there's also a concern about if you add too much to the stages, it'll act as a disincentive for EPs to participate. And when you take out your calculator, we know that there's a $44,000 maximum, but if you complete the first 3 years of stage 1, you've received $38,000 of that 44. So now you've got $6,000 to cover stage 2 and stage 3, which of course is woefully inadequate. And I think we've heard here on the panel, there's simply not enough time between stages, so we're certainly advocating for a change there. And one thing is interesting, when you go on to the certification website and you look at the 2011 list of certified vendors for complete ambulatory products, you'll see that there are over 1,800 products currently certified for 2011. But when you change that to the 2014 criteria, that number is 57. So that is a huge, heavy lift for the industry. Clearly, the vendors are being challenged to meet the timelines. And again, vendors are not required by law to do anything with meaningful use. They may be required through contracts, but this is completely up to the vendor themselves to decide whether or not to be certified for stage 1, stage 2, and for stage 3. So in terms of suggested modifications, from a general sense, we're always looking for easing the burden on the provider for reporting. And one of the things that would be relatively simple, and again alluded to by the panelists, is why don't you take a leaf from the PQRS, the Physicians Quality Reporting System book, and allow group reporting. So one-time reporting of the group data, it streamlines the administration on both sides, and again would recognize that the vast majority of care in this country are provided in group practice settings. Obviously, avoiding multiple reporting of the same data. Certainly not the first person to say that. It's been in government reports. I know CMS and ONC are actively pursuing this, but there's no reason to be reporting the same exact data to multiple programs. And again, permitting flexibility both in the criteria and the time. That all or nothing approach is something that I think we have some concerns about. And also, think about expanding the hardship exemption category of unforeseen circumstances to include problems with the vendor, not with GE, thank God, but for potentially other vendors who are struggling to meet the requirements. And if, for example, if an EP attests successfully for stage 1, but their vendor is unable to certify for stage 2, that EP shouldn't be subject to penalty adjustments. In terms of stage 2, we're on record with a lot of other provider organizations in calling for an extension of the timelines, extend the reporting period for stage 1 to allow EPs to continue to be actively engaged in this program, and of course build in additional flexibility. And we've also called for a comprehensive survey of the vendors to find out how many of them plan to be certified for stage 2 and ultimately for stage 3, and find out what the barriers are. What are they encountering in their development process that perhaps CMS and ONC could assist with. And finally, in terms of stage 3, of course, we need to evaluate the first 2 stages. There's a tendency, as we saw with stage 2, to get the proposed rule out prior to really understanding what the environment was for stage 1. And for stage 3, exactly the same thing. We need to understand what's happening in the industry prior to pushing additional functionality and higher thresholds on EPs. And we say here, engage patients, don't force them. And I'll call out the WEDI report as well that came out yesterday. A huge section of that report is focused on patient engagement. We really need to tailor this program and our efforts to allow patients to be more engaged in their own health care. Consider usability criteria. There's an AMA study with RAND which shows that 80% or so of physicians are dissatisfied with their EHRs. I may get that wrong, but there's a high level of dissatisfaction with EHRs, and that is because they're not easy to use. So rather than focus on adding more functionality, let's get the original functionality right. Let's make it easy for physicians, useful, make sure they don't lose time and lose productivity when they're using this technology. And my last point is a simple one, and that is the most vulnerable providers, the ones that have had the most challenged time moving to meaningful use, are those in the small practices in the rural areas. The regional extension centers have been wonderful lifelines for these folks, and they've acted as real mentors for these smaller practices, yet many of those RECs are being defunded. So a good opportunity to pump a little bit more money back into the RECs to let them assist providers move to stage 2 and stage 3, but also they have the ear of the small providers. So why not allow them perhaps to expand their portfolio to include other health information technology issues like ICD-10, like admin SIMP, and really push the ball down the field. Let's do that, Tim.
Great. Thank you, Rob, and thank you very much for all of our panelists. So now for some interactivity here with the audience. So if you could start formulating your question and come on up to the microphone, I'd like to go ahead and pose out kind of a question while everybody's kind of thinking what their question is going to be. In maybe 60 seconds or less for each of you, think about what can CMS do exactly to ensure that stage 3 leads to improved outcomes. So not everybody answered once here. Who wants to go first?
I can go first. Go I'm a big proponent of trying to look at best practice across the country. And I think there are several organizations, some of you in this room, who've actually demonstrated great outcomes using process or workflow changes and optimization. I think pulling those, understanding what works, and then implementing that in a scalable fashion would be the way to go.
Maybe just to add to that, I think we need to have some research. I think there's a sense that if we do this, the outcome will be improved, but there's no evidence. And I think ICD-10 is a fine example. So I think we need to fund some research, get to best practices and use cases, and then use that to build an argument for moving forward.
Okay. Linda?
Understand that today's environment of care is changing. No longer does the physician sit there passive and wait for the patients who have self-subscribed that they are ill to show up at their appointments that they decided that they needed to come to. Instead, providers are now thinking about who across the population needs my help today, even if they're not in my office in front of me, and making sure that the providers are armed with the information that they need to be able to move into that world.
Great. David?
I think one thing I mentioned earlier was that we should be looking at the trailing edge problem. What are the impediments we have in the system to keep us from reaching the goals? We always look at the leading edge problem, but the fact is that if you look at organizations, the trailing edge problem probably contributes as much to what doesn't happen as it does to what does happen.
Okay. Any questions yet from the audience? Otherwise, I'll kind of keep going here. Actually, this was kind of a follow-up question, David. One of the things you and I had discussed kind of offline was about process and the impact of meaningful use stage 1 and 2 have on the process as an organization. Can you talk a little bit more about what have you seen within your organization and kind of what is your organization doing to adopt or adapt, I should say?
Well, I think the biggest problem I see right now is to understand the workflow that is tied into a particular change. What you find is that we don't often understand the workflows that are in practice in the physicians until we implement a change. And when you look at the workflows, what you see is that software is written for a particular system, for example, matches the design that somebody in the software has built many, many years ago. It may be inherent to the database that's in the system. It may be inherent to some fundamental design approaches that went back 30 or 40 years. But that has ramifications in terms of the workflow. And so what you find is the workflow that when you install certain things, Epic, for example, assumes certain workflows, and Cerner assumes certain workflows. And the workflow itself, when you try to run both systems side by side, which very few organizations are crazy enough to do except ours, you have to see what it takes to make the two workflows compatible. And that itself, at a meta scale, is even more important when you start doing community things. We're finding, for example, all the Cerner systems and all the Epic systems can talk to each other, to themselves, but when they cross to each other, then you have some barriers.
Okay, great, thank you. I think we have a question from the audience.
Is it okay to ask you the question?
Sure.
Okay, so this is what the government has done so far, and I hope they don't send me to jail because I'm in CMS. When we were developing this thing to change healthcare, by the way, my name is Shafiq. I'm the CIO for Hackensack University Medical Center. I'm a doctor too by profession. So we incentivize the hospitals so they can put the damn EHR in. We incentivize the physicians so they can get some interest in the electronic health record. We forgot the patient. So is there any way that you can at least, if the patient for the first time uses the portal, take one copay off, and if it really checks the labs the second time, take the second copay off? Mm-hmm. And do you know why patients really have to go to the physician's office to get a lab result so I can bill for it? They can get that answer on the phone. They can get the answer on the e-visit also. So somehow if you incentivize the patient to do electronic consults, that'll stop a lot of things too. So those are the two suggestions. And this panel, the thing that all of them talked about, the following thing is this, that the research and outcome cannot happen till you get to the outcome phase. Our problem in the country is that we're still struggling putting the EHR in and trying to understand it. And everywhere we have put the EHR in, it has increased the time. It has taken more time to put it in, it has taken time to put it out, and it has taken the time of the physicians to work on it and the nurses' time. Until that day comes when we have scanners in our coronary artery, and 3 days before we have an event, it tells our cell phone, go get a STEMI, and you'll be fine.
I'll answer as, from my perspective, and I think one of the things you pointed out was actually in the 2013 WEDI report, there was actually a section where we actually talked about innovative encounters, and that as an industry, that's an area where we will be moving into. The question is obviously there's legwork that has to be done, evaluating best practices. We know that, for example, Kaiser Permanente, I think, is doing over 20 million e-visits this year, with very high patient satisfaction, but how do we actually look at other aspects, other models to be able to deliver on that? So I think as an industry, we acknowledge that and I think see some real value in that area. Does anybody else want to comment, Rob?
Yeah, just real quick, and the Kaiser model is a good one, except they're both the provider and the payer, so it's a lot easier. We've had a CPT code for e-visits for more than a decade, yet most health plans do not pay for that. So, and again, there's privacy and security concerns from the provider side. Emailing PHI back and forth with the patient is simply not the best approach. So I think if we can get to a more secure, like direct, a more secure messaging system, that frees that up a little bit, but still there has to be an economic motivator, because again, if you're treating patients and not being paid, then it's not a good use of the physician's time.
David?
I'd just like to quote Clem McDonald, who made a comment, and of course, all of you know he's head of the National Library of Medicine. Some 30 years ago, 20 years ago, he made this comment. He says, physicians love to get data, they hate to give data. And one of the things he observed when he was at Regent Strive was that whenever they built CPOE, they would take 1 to 2 more minutes per patient. And so it was not unusual for the average resident, for example, to have to spend 2 or 3 hours an extra a day, which now under the new residency rules you can't do. But I think what came out of it was his goal was he would spend a couple of months to a years to try to get that time back to the physician by working the software to do things that the physician would have to do on his own. And some of them include little note cards that he would do. This is the kind of stuff I think if we're to be successful, we're going to have to. We know we take time away from the physician when they have to enter discrete data. We're going to have to give something back, and we have to look at what it takes to give it back, and that's going to take time.
Thank you, David. Lori?
My question, you hit on it about reporting periods and the time frames, and although in stage 2 it sounds like it's a nice thing to only report for 90 days, I'm wondering what your strategy is on 2 measures. One is the patient reminders measure, where the denominator is any patient that has been seen twice in the prior 24-month period. However, the reminder needs to be sent during the 90-day reporting period. And if you're a specialist, perhaps you saw the patient twice in 24 months, but you've now discharged them. What are you going to remind them of? And secure messaging. So the denominator for secure messaging is the patient has had a visit with the provider within that 90-day period. Likely they're not going to need to send their provider a message if they have had a face-to-face encounter with them. However, the message needs to occur within the 90-day period. I would prefer a year-long reporting period, really, even though we're struggling to ramp up for stage 2, despite the fact that we're all HIMSS level 7, one of the most wired, academic medical centers. So we're struggling with that, and I would like to know if you guys have a particular strategy on how you're going to deal with those 2 measures specifically. If you can solve that for me, I would.
Next question. Maybe you have any thoughts?
No. We don't have an answer.
Okay. To be continued, I think, is the answer. So.
John Dodd from CSC, and my health has not gotten worse today. Some people ask a question in the beginning. The question is, could there be some initiative that is more qualitative for meaningful use instead of the PQRS, the checklist approach? Could you have success stories, inhibitors that are there, really have a grading system between A to F or it could be longer around each of the key criteria? And could that be a suggestion and maybe a WEDI paper on something like that? That there is, I think you made all very good points from different perspectives. And the world is not, I'm an incrementalist at heart, and there's an incremental way to get this improvement. And everything's local. And there are other hospitals that have the same problems you do, I'm sure. University of Maryland, I know this. So anyway, is that valid? Does that make sense?
Sure, maybe we'll take that.
I can try to answer it. I think it totally makes sense, but there are some challenges that come with it. I think it makes sense because we've been laser focused on reporting and checking the box and the letter, and we may have not emphasized as much on the spirit of what meaningful use was all about. So I think your point is right on. I think the challenge becomes how do you then measure that, and it's harder to measure qualitative. I think there are ways of doing that based on, again, coming to outcomes where appropriate and being able to show levels of outreach and what have you. So I think I agree with that theme. We just need to kind of understand how best we can measure that.
Well, and I think David said it, where physicians like to get data, and they do. They like to be. They like to see where they are in the rankings. They like to compare themselves with others, and I think that's an opportunity. But the key is, I think, is to have that feedback loop be quick. So if you report, you want to get something back to say, okay, you're in the low percentile, you need to change your workflow, the way you deal with your patients. So that feedback loop needs to be immediate, or as immediate as possible. Right now, feedback reports for e-prescribing and PQRS, it's 6 months, 12 months. It's a long time. Not to, it's a challenge for CMS too. They've got to deal with this data. And so, reporting is one thing, but if we don't do anything constructive with the data, then why are we reporting in the first place? And just to add more challenges, of course, we're moving to ICD-10, which is a whole new code set, so the reporting is going to be even more convoluted, certainly for the next few years.
Okay, well, I think we're out of time with that last comment, so I just want to thank all of our panelists very much. Appreciate all your wonderful remarks.
Thank you, everyone. We will take a quick break and be back at 2:15 for our final panel of the day on electronic clinical quality reporting. Thank you.
So there's some magic press releases coming out at 4:30. I just got a case from our news director. It's coming out at 4:30.
It is 2:15, so we will be getting started with our final panel of the day. If everyone can please begin getting to your seats.
The gentleman?
No, I'm not now. Okay, unfortunately.
Thank you. We will be getting started in just a moment. So everyone, please either come to your seats or exit the room and continue your conversation elsewhere. Okay. Thank you very much. We are ready for our final panel of the day. This is on electronic clinical quality measurement, and so I will turn it over to Kate Goodrich from the Centers for Clinical Standards and Quality.
Hi, everybody. My name is Kate Goodrich. I am the director of the Quality Measurement and Health Assessment Group here at CMS, and our group oversees a number of public reporting and quality reporting programs, as well as some of the pay-for-performance programs, and we also are responsible for the bulk of measure development within CMS, including electronic measures. So thank you for attending the panel. Let's see, I have a few slides to get us started off. We first of all have a distinguished panel here that I will introduce to everyone as soon as we go through the introductory slides. And that's me. Okay. So as many of you probably know, at CMS we have over 20 quality reporting, public reporting, and pay-for-performance programs, and several of which use electronic clinical quality measures. We've identified them here on the slide, sort of bucketed into settings or types of programs like payment models. We have the EHR incentive programs, which of course you all are very familiar with, but we also have a number of programs for the post-acute care setting, a number of up-and-coming programs or new models through the Innovation Center, and there are quality reporting programs through Medicare Part C and D, and soon through the health insurance marketplaces. So why are eCQMs in particular important? So eCQMs, importantly, are standardized performance measures that are derived solely from electronic health records. I think it's important to note that with other types of quality measures, such as those derived from claims or from chart abstraction, while there is some standardization, it is not as robust as with eCQMs. And I'm just going to abbreviate and say eCQMs to make it easier. eCQMs support the achievement of the three main healthcare aims, which include better health care, and lower cost or affordable care. That's our very famous three-part aim. These three aims also form the foundation for both the National Quality Strategy, which was first published in 2011, as well as the very recently published CMS Quality Strategy. That is out on our website right now at cms.gov, and we were asking for comment from the public on that. And there are six goals underneath that CMS Quality Strategy, which should sound familiar to you if you are at all familiar with the National Quality Strategy, which includes making care safer by reducing harm caused in the delivery of care, strengthening person and family engagement and partners in their care, promoting effective communication and coordination of care, promoting effective prevention and treatment of chronic disease, and working with communities to promote best practices of healthy living, as well as making care affordable. And under each one of these goals are a number of very important objectives, as well as more specific initiatives and soon to come metrics to follow each of these goals. So the use of eCQMs is helping to achieve many of these goals, and we have, as I said, identified a number of much more specific objectives and desired outcomes to help drive improvement really across all settings of care and also within the community. So eCQMs enhance quality measurement by providing, number one, greater clinical relevance. EHRs can capture clinical information in a much more complete, reliable, and precise way. It is easier then to be precise about what is being measured and to develop a better understanding of performance improvement areas. Again, paper-based measures may not be completely standardized, but I think it's also important to understand that there are limitations to EHR data, such as that some elements may only be captured in free text fields. There's lower provider burden with eCQMs, so collecting paper-based measures and abstracting measures from regular charts is very costly, very labor-intensive. It requires manual abstraction of data from both administrative systems as well as from charts. And then collecting ECQMs is easier because EHRs are designed to uniformly capture and electronically extract clinical data, which then reduces administrative burden. And we believe that ECQMs are more robust types of measures than other CQMs. So claims data do not provide the same level of specificity that are needed to identify clinical outcomes as we can get through the EHR. This helps to improve on a number of factors, in particular for risk adjustment for outcome-based measures. So I want to talk a little bit about the measure development life cycle. This is something that we live and breathe every day in our group. So CMS has published for several years now something called the CMS Measures Management Blueprint, which is what it sounds like. It's a blueprint of how you develop measures from beginning to end. It provides very detailed information on every step of the measure development process, from identification of gaps in measurement all the way through to NQF endorsement and implementation. There are 5 key stages. We've basically bucketed all the information from the Measures Manager Blueprint into these 5 key stages here. So these include measure conceptualization and selection, and this is a point at which a number of stakeholders get involved in our process by suggesting measure topics to us, by helping us to identify where there are performance gaps, so not just measurement gaps, but true performance gaps. And then we decide what measures that we would like to develop at that point, along with multiple stakeholder input, and move forward on that. Next comes measure specification, in which we draft measure specifications, and then we conduct initial feasibility testing to see if those data elements can be easily abstracted from EHRs. Further on down the line is further measure testing. Importantly, measure testing is done at multiple steps along the way of the measure development life cycle. And then measure implementation, in which within CMS and with several of our partners, we participate in large rollouts for our programs and for implementation of new measures within our programs. This happens through the federal pre-rulemaking and rulemaking process. And then, of course, on the back end, we have to develop our systems or code our systems to be able to accept these measures, and a lot of education and outreach also goes into this. And then finally, measure use and evaluation, where we continuously look to see how our measures are performing in the programs that they're in. We do that through a number of both qualitative and quantitative methods. So this slide presents the phases as though they happen in perfect sequence, and the reality is that they don't. It's a very iterative and integrated type process. Again, measure testing begins early. It informs both final measure specifications as well as measure implementation. There's no one specific timeline for measure development and implementation, and it can actually be quite variable. And I think we're going to actually ask Manette and probably Cindy also to talk a little bit about this and what we're doing to try to make that process a little bit more standardized so that we can reduce the variation and waste in the process. Measure developers, healthcare providers, patients, vendors, and other stakeholders all play a very important role throughout the entire life cycle. This is not just something that happens between CMS and its measure developers. So I hope that this slide provides some context for you for the discussion around the measure development life cycle. And I also want to highlight something that we've been doing at CMS that, again, I think Cynthia and Minette are going to talk a little more too, which is the lean processing that we've been undertaking within our group and with our partners at the Office of the National Coordinator to better standardize how we develop and implement measures from end to end. And we've also been working with the National Quality Forum to extend that lean processing through to the endorsement cycle as well. So one of the drivers, in fact, probably the main driver for the development of ECQMs was, of course, the EHR incentive program, also known as the Meaningful Use Program. In a couple of weeks, we'll be rolling out Stage 2 for eligible professionals, and we thought that this would be a good time for us to recap what we've done to improve from Stage 1 to Stage 2 and how we can continue this process through Stage 3. And as with the launch of any new program of this size and this scope, we recognize that there are many challenges that still remain, many we've already experienced and many that still remain in the measure development and implementation process. So we've assembled this panel today to address ways that we may be able to overcome some of these challenges for future stages of the program. And the focus of this discussion is to engage stakeholders that we've convened here in a dialogue on solutions, lessons learned, and the way forward for quality measurement. So now I'm going to turn to introduce our panel. And I'm going to start here with Dr. Frederick Bloom, who I confess I haven't met yet. So Dr. Bloom is the Chief of Care Continuum of the Geisinger Health System and the Medical Director of Quality and Performance for Geisinger Health Plan. He's responsible for designing reliable value-based systems of care for chronic disease and prevention in the Geisinger Clinic. He is the co-author of numerous peer-reviewed articles that show the improved quality, reduced costs, and positive return on investment of these systems of care. Dr. Bloom has taken 37 Geisinger sites to level 3 NCQA patient-centered medical home recognition and currently serves on the NCQA Patient-Centered Medical Home Recognition Review Oversight Committee. And he was responsible for strategic alignment and operational success of the elements of Geisinger's care continuum, including nursing homes, home health agencies, and CareWorks retail walk-in clinics. And he also develops pay-for-performance partnership relationships for all providers, including thousands of non-Geisinger primary care and specialty providers. And he's most recently helped lead the CMS demonstrations for Geisinger involving accountable care and is the Chief Medical Officer for the Keystone Accountable Care Organization. Cynthia Cullen is a Principal Program Analyst at Mathematica Policy Research, where she leads clinical quality measure development projects with a focus on requirements development and testing. And she currently serves as the Project Director for a contract with CMS to develop, respecify, and maintain clinical quality measures for the Medicare and Medicaid Electronic Health Records incentive programs for eligible professionals. In addition, she has previously supported program and measure development activities for other CMS quality reporting programs, including our hospital outpatient program, our inpatient psychiatric hospital program, and the PPS-exempt cancer hospital quality reporting program. Minette Havayana is a nurse by training and has had clinical and administrative experiences at a medical center, health plan, and now here at CMS working with me. Prior jobs include utilization review, patient safety analysis, and a staff nurse in a neonatal intensive care unit, adult transplant unit, and pediatric operating room. At CMS, Minette has been involved with Hospital Compare, Medicare Part D, and then currently with the Meaningful Use Program. And she is currently the government task lead for the development of eCQMs for eligible professional measures. Roles and responsibilities include coordinating and collaborating with other federal agencies, in particular with the Office of the National Coordinator, with our measure developers, and many other components of CMS in implementing eCQMs for a number of CMS programs. And Mickey McGlynn is the Senior Director of Strategy and Operations for Siemens Medical Solutions and the Chairperson for the Electronic Health Record Association. Mickey is currently responsible for Siemens' portfolio strategies and has over 28 years of healthcare experience, including holding leadership roles in all key aspects of business development, software development, sales support, marketing, and government affairs for Siemens IT Solutions. In partnership with key stakeholders, she leads efforts for Siemens and the EHR Association on government and industry efforts relating to the development, implementation, and value of health information technology. And finally, Jenny Meadows, a nurse by training, is the Executive Director, Corporate Strategy for McKesson Corporation, and is responsible for regulatory trends and interpretation and critical review of market position and product development strategy related to healthcare regulatory topics, focusing on quality improvement. Jenny has more than 25 years' experience in clinical informatics and HIT, with an emphasis in the areas of product management, strategic planning and analysis, knowledge management, and clinical quality analytics. And prior to her current role, she served as the Director of Clinical Informatics at Shared Health, where she was responsible for determining clinical product strategy and other items. She also is a member of the EHR Association, which I mentioned before, of the Executive Committee, and she chairs the EHRA Quality Measurement Workgroup. And Jenny was recently elected to the HIMSS Nominating Committee and serves as a liaison to the HIMSS Quality, Cost, and Safety Committee. She's a member of AMIA and serves on the AMIA Membership Committee and participates in several of their work groups. Okay, thank you. Welcome to all of you. So I'm going to start with the first question, which is about the life cycle of eCQMs and what your particular role is in that life cycle. It's important to note that one of the things that we realize when we go out and talk to a number of stakeholders is that there isn't always a broad understanding of exactly what goes into an eCQM, and certainly about the life cycle as a whole. So I think it would be helpful to get that perspective from each of you. So I'm going to actually start with Minette to talk a little bit about the work we've been doing or that she's been doing, and particularly around the lean process.
Sure. So again, so first, as we talk about eCQM in general, this does apply to both the measures for eligible hospitals and eligible professionals. So as Kate had mentioned earlier, we finalize measures based on a lot of stakeholder input and based on the national quality strategy domains. Once we have decided on what those measures are, and to be able to provide these measures to the provider community, we do contract with measure developers such as Mathematica to get us through from beginning of a measure to the end of the measure. But having said that, though, we are always looking, especially based on previous experiences from previous stages, we're always looking to improve our process. We're always looking to be innovative. And for stage 3, based on our stage 2 experience, we are implementing the lean process, as Kate had mentioned earlier. So what that means is for stage 2, we batched all the measures. So we kind of put them through the rigor from beginning to end, and then handed it off to the next stakeholder, which would have been certification, the Office of National Coordinator. And at the end of that process, we found that there were a lot of defect rates and a lot of waste that went on doing it that way. So for stage 3, what we're going to do is we might, let's say, for example, have 10 measures in the queue. We'll take one of those measures, and possibly 2 if they're like measures, and put that through the rigor from beginning to end. And in this way, we find out what our areas of waste are. We find out where we can diminish defect rates before we apply it to the next set of measures or to the next measure. And in that way, again, the goal is to have more error-free and stable measures when we are done with them.
Great. Thank you. I think it's worth noting that for stage 2, that our eCQM life cycle we've calculated was anywhere from 3 to 5 years from beginning of the concept of what measures we want all the way through to implementation. And as Manette noted, 100% of our measures had defects in them and needed correction. So we're very excited about the work that Manette and Cynthia are doing together to reduce waste and make sure we have error-free measures. So Cynthia, can you then talk next about your perspective on this from the developer's point of view?
Certainly. What we do as measure developers is we start with the priorities that CMS has provided to us, aligning with the National Quality Strategy and CMS's strategy. That provides us the source for the first phase of measure conceptualization. In this phase, we look, working from the priorities, we look into the published research, we look at clinical guidelines, we talk with clinical experts, we talk with patients, and we obtain a broader perspective on what potential gaps are and potential areas for development are. During this phase, we also look at existing measures that are out there. We're looking for opportunities to leverage work that's already been done and to use original measures or existing measures as potential building blocks for more extensive measures going forward. Once we have measure concepts in place, with the approval of CMS, we move on to the next phase, which is the measure specification process. Measure specification gets us from idea to actual technical specifications that can be used and implemented into an EHR system. In this phase, we bring in some additional stakeholders. We'll have vendors, and we'll talk with them to find out what the data availability is, what the current data structures are. We'll talk with providers to get a better understanding of what the workflows are and how the data is captured in the field. We work within the approved data structures and data definitions, vocabularies, and then define the measures. Once we have defined measures, we move into a testing phase. And testing has a couple of different flavors. From the measure development perspective, testing is really looking at the quality of the measure itself. So from a feasibility aspect, sure, we can pull data from an EHR and we understand it's feasible, but does that necessarily mean that the measure is good? What we're looking for defining a good quality measure is, does it map to the measure concept that we that we're trying to model here. Is it a valid measure? Does it align with what we think? Are we actually measuring what we think that we're measuring? Is it a reliable measure? Can we distinguish between good performance and poor performance? Those are really important aspects. For this is when we start going out into the field. This is when we need data. We obtain data from providers. We go to provider sites and we abstract or extract data from their EHR systems and run statistical analyses on them. We have conversations with providers and with vendors, with informaticists at provider sites to get a better understanding of how they do their work. We obtain their opinions. Do you think this measure really works? Do you think it is distinguishing between your high-performing and your less high-performing providers, excuse me. It's a very extensive process. It's a time-consuming process. It's a very iterative process. We take the feedback that we get from this. We get to take feedback from public comment. We just recently closed the public comment period on 2 measures that we're developing for CMS. We got some very interesting comments back, very useful comments back, because the comments are coming from people in the field who are going to be the ones that use this measure. They're the ones who are doing the day-to-day work on this. Once we complete our testing phase and we've gotten our specifications, we then hand them over to CMS for their review and consideration. There's a rulemaking process. The Measure Applications Partnership also reviews that, a public-private partnership that looks at potential suitability for measures and programs. And then once it's accepted and published into the program, we hand it off, and then I think the vendors pick it up.
And really quickly, before I move to Mickey and Jenny, Cynthia, would you mind just at a very high level defining 2 terms, which would be retooled measures and de novo measures, and just very briefly what the difference between the 2 are?
Sure. A retooled measure is we take an existing measure that has been defined for a particular data source, like claims or perhaps paper-based, and then we translate it into an electronic format. There are some challenges with that. There's not necessarily a one-to-one relationship, but what we do is we make sure that the intent of the measure is maintained. De novo measure development is starting from scratch, so it's going through the entire process, doing the literature reviews, obtaining the information, making sure that there's a strong evidence base for the measure, developing the specifications, and then doing the fieldwork testing. De novo measures, a lot of them have undergone some original testing, so the testing methodologies may be a little bit different, but it still gets us to the same point at the end. But the primary difference is starting from something that's already existing and starting from scratch.
Great, thank you. So I'll turn to Mickey and Jenny, and I think what we'd like to hear about next is when the measures are ready to go and handed off to you, from your what's your role in terms of programming the measures into your EHR systems or into your products and testing those measures, and then the next phase of actually rolling them out to providers who are going to actually be using those measures. So I'll let you decide who goes next.
I'll go first. Oh, no. Do you want to
go ahead?
Sorry. So we really applaud the efforts of CMS and ONC in really getting the vendors more involved and early on in looking at new measure concepts and the feasibility of measures, because as we saw, and I'm going to kind of describe the process we went through with stage 2, which we're really hoping will be vastly improved for stage 3. We think that that will happen. We usually don't get the measure specifications until very late in the process, which is sometimes very challenging for us. So as you all know, when CMS first decides what measures they might have in a stage of meaningful use or for other programs, they list them in the proposed rules. And we really can't comment on those listings of measure names because we don't have a specification to look at. So we really can't do much with the measure as far as evaluation and analysis until we get that fully detailed measure specification in HQMF. HQMF may not be a term that everyone is familiar with in the room, but it's really the actual programmatic representation of that measure and the measure logic. And that we really rely on that in order to know how we need to implement it in our software. So when we get that specification, which for Meaningful Use Stage 2, we received them late December of last year, we really start looking at the HQMF and evaluating whether, first of all, we can actually consume that measure into our measure engine, which will do the calculations, whether the logic makes sense or whether it's going to require some additional programming. And many times we found that because of the way today the HQMF is actually designed, we have to do a lot of additional work on measure logic for some of the more complex measures especially. And a lot of those complex measures are resident in the eligible hospital or inpatient area. Once we've kind of looked at that, and sometimes simultaneously, we're also looking at the measure and analyzing what data it's requiring from our EHR for the providers to collect. So we have to do a really detailed analysis on that, because sometimes we'll find that the measure is actually looking for data that today is not part of the normal documentation and care process that our providers are following in the EHR, which presents some challenges. I'm sure Dr. Bloom can talk about that, that aspect of it, as he's the very end of this whole process. So if there are data elements that aren't resident, then we have to develop them, and we have to make sure we not only add them to our database, but we also have a really detailed design process for our customers to understand where these data elements are going to reside, how they should use them, and we actually do very detailed flowcharts for our customers. That's one thing that we don't actually get today with the measure specifications, but we found they're invaluable for our customers to actually do a complete flow. We do it in Visio, but obviously give it to our customers in a really easy to read document of each measure and what data is needed, where it comes from, and how they can actually kind of understand their workflow when they start to implement that measure. So that's a really critical point that I think we spend a lot of time doing, are those workflow documents. And then finally, we do additional documentation for our providers in understanding, what they need to do to train their end users and to really implement those measures and make sure that they're getting the results that they're hoping to achieve. We do a lot of work around the whole calculation and verifying the accuracy, and of course that's also part of certification. And I'll maybe let Mickey talk a little bit about the certification process.
Okay. Certification includes the ECQMs now. It's a component of it. It's been, I think as Kate alluded to, it's our first time through, so it's been quite a challenge. The first time, we're all looking forward to the opportunity for the improvement in the future. And actually that's the point I want to make, in that Ginny did a nice job of kind of describing each of the steps that we take once we get, as you said, a complete ECQM. But the reality is, and we're seeing this now as we roll it out, as we have worked through it for the first time and roll it out to our customers, we're in a fundamental shift, in a difference in the way we're doing quality measurement. So going from the abstracted measures that really, a lot of the data is collected completely outside and does not even really impact the day-to-day workflow of the physician, to a process that does impact the physician providing the care every day. And it's linked to meaningful use now, it's linked to certification, it's linked to so many things, other programs in CMS. And I think a role we want to see this whole group have is stepping back and really looking at the implications of that, so that as we go into the next phase, we all do better, right, in how we develop them, implement them, and roll them out to achieve the goals that we fully support that you described in the beginning. We see the value, we see the opportunity, just feel like let's step back and look how we can accomplish that together.
Great, thank you very much. And then finally, Dr. Bloom, Can you describe from your perspective what the real benefits are of using electronic quality measures, and even if you'd like to touch on what some of the challenges in your organization have been as well?
Well, as the provider representative on this panel, I am going to comment on the implementation challenges and burdens, but for those of you who don't know Geisinger Health System, Geisinger Health System is a 1,000-physician multi-specialty group, a 5-hospital system, and a 400,000-member health plan in central and northeast Pennsylvania. We've been involved in reporting quality measures to CMS for a number of years. We were in the physician group practice demonstration and started reporting quality measures back, starting with the beginning of that program in 2005, and have continued up until this day. We have a long history of use of an electronic medical record starting back in 2006, and have all of our 1,000 physicians in 4 of our hospitals all on a paperless record. Kate talked a lot about the benefits of having accurate clinical information in a reporting system out of an electronic health record, and I don't think you can underemphasize that having accurate clinical information really is critical to your process redesign, your internal improvements, and is very, very valuable. Beyond that, reporting it nationally and having benchmarks and really being able to determine value in healthcare, I think can revolutionize the way medicine is paid for and practiced in this country. So this is a tremendously important topic. But with that implementation of these measures come implementation challenges and burdens to the provider that go along with that. And just to give you an idea of burden that we're talking about, we participated in the physician group practice demonstration, reporting to CMS measures similar to the PQRS program through a tool that's similar to the GPRO tool. The PGP ended in 2010, and we entered another demonstration called the transition demo to transition the group practice participants to a shared savings program. It had a very similar quality reporting through a tool similar to the GPRO tool that's available now. In 2012, to report the required quality measures for our group through a measure similar to the GPRO, where we had 411 consecutive patients that we had to report for each of the measures, our group spent about 2,800 hours of time collecting and implementing those measures, about $80,000 just to report those quality measures for that one program. Many of the measures, even though they were electronically reported through the tool, weren't good ECQMs in that they weren't structured data in an electronic medical record. They might ask for a hypertension plan of care, which required review of a progress note that required, even sometimes the eligibility of patients for the measure required chart review. And so having an accurate electronic quality measure, clinical quality measure, that reduced that reporting burden could have tremendous impact on multiple organizations, well, all the providers around the country, and allow them to really start to participate in a much more meaningful way.
Yep. Great, thank you. So I do want to actually piggyback off of that a little bit to talk about challenges that you all face, and some of you have touched on that already. But one of the significant challenges to the development of ECQMs is how to incorporate adequate testing. So I would love it if maybe, Cynthia, you could talk about testing of the measure as it's being developed and some of those challenges. And then maybe Mickey or Jenny, you all could talk about the testing of the measures once you consume them or code them into your EHR systems. And you've already touched a little bit on that. But I think that would be helpful to understand, because that'll be sort of the springboard for how we think about improvements for stage 3 of meaningful use. So maybe you want to start, Cynthia?
Sure, that'd be great. Testing is really one of our biggest challenges. What we need in order to test the validity and the reliability of the measures is data. Finding testing sites, that have data available has been a real challenge for us. The recruiting process takes quite a bit of time, just identifying sites that may have the data available to us. And we understand that physicians' primary purpose is to practice healthcare and not to necessarily support the research. So we do have challenges related to that. One of the challenges we've had more recently is as we are moving forward to address CMS's needs and desires for, say, outcomes-based measures, is that we are pushing the envelopes of what is currently collected. And I'd like to give an example. Goal setting is something that we've been looking at. It addresses the CMS's priorities for patient engagement. It provides an opportunity for physicians and patients to collaboratively work together, have the discussion, set the goals, and then hopefully improve healthcare. We've worked with, we're trying to identify sites that might have this information, and we, of course, started first with the vendors to see how are they addressing goal setting. Ginny, in fact, participated in one of the discussions that we've had, and we've learned that goal setting has been addressed in a variety of different ways. Some vendors have taken the approach that let's look at quantitative goals. So let's say we have a patient who needs to lose weight, and they'll say, you should lose 10 pounds within the next year. So they'll put that quantitative goal in there, and then every time the patient comes in, you'll weigh the patient, and then you'll be able to track progress towards that goal. Other vendors have taken a slightly different approach and look at it from a more qualitative aspect. You need to lose weight. And then they may have some information related to the difficulty of the goal and the importance of the goal. It's recorded a different way. As Dr. Boom had mentioned, some of the challenges of having discrete data, there's a bit of a challenge there. We've talked to other vendors about this, and they haven't addressed goal setting yet. So we have a lot of variety in what data is currently available. One of the ways that we think that we might be able to address those challenges is to have opportunities where we can work directly with vendors and with providers to maybe prototype some of these measures, define some data structures, get them defined, get them integrated into a system, get them out into the field, and allow us to collect the data and see how that works.
Mickey or Ginny, if there's anything else related to implementation specifically that you'd like to highlight that has been a challenge, that would be welcome as well.
Okay. Specific to the testing aspects. So there's multiple levels of testing that happen in software development, unit testing, system testing, integrated testing. But a key test here with the question is the testing tool that we have available that we use to test our measures, and then we use the same tool through the certifying bodies to test them. So this is an area that, as you said, an opportunity for improvement. I would say, I think, again, it's all new, right? So it's the first time through. So everybody's doing their best, but with the compressed timelines, I'm not sure there is always time to do that adequate testing of the tools, so then there can be adequate testing of the measures. So the main tool we use is Cypress. Things are evolving. Many of the vendors are certified now, but it has impacted certification. I'll just say from our certification from a Siemens perspective, I think there's been a total of 5 new versions of the tool, 2 during our actual certification time frame. So that has an impact and delay on the overall program and getting certified software to the providers, which we know is a key item. So I think as we move forward, we certainly want to look at how to find ways to test the measures and test the tools that test the measures so that together it's a streamlined, lean process that everyone can feel comfortable that the measure is clean, the software is clean, the tool that tests the measures is clean, ultimately to get to a streamlined result in an expedient time frame.
Okay. Do you want to add? And I'll add a little bit to that because we've definitely been working very closely with ONC and with the MITRE Corporation who developed Cypress to think about how we can improve that whole process. And I think we're seeing a lot of activity now and a lot of improvements starting to happen, there's still some things that we really need to think through because, as Mickey said, we use Cypress ourselves internally as a testing tool because it's a really, can actually tell us whether we're calculating the measure correctly and whether we're getting the result that's expected. One of the challenges is with the frequent updates to the Cypress software, we've also found a lot of software bugs in the Cypress tool itself. So we're really trying to encourage MITRE to work with us and helping to test each new release that comes out of the Cypress tool as well, because we think that will really help eventually kind of assure the quality of what's happening. And it's also going to reduce the burden on the vendors and help provide more timely updates to our customers when, 500 vendors aren't all trying to resolve the same issues around why isn't this working. We can have a handful of vendors who can work with them and actually validate the fact that this is correct, this is right, the measure data that we're feeding in is correct, and everything's going to work once we go to certification. So I think that's a really key point. The other point I was going to make was around what Cindy was talking about with the new process that we're trying to do in testing and looking at the feasibility of measures very early in the process, which we're very encouraged about. We think that's a fabulous way for the vendors and the providers. We'd really like to see as many providers as possible be involved in that process as well. Really understand if the measure's feasible and whether the data actually does or should reside in an EHR and should be part of the workflow of the provider. I think sometimes, we don't always think that through, and I think this process is going to help us really understand that whole feasibility issue. One of the challenges, though, that we've had that we're hoping will improve as we think about the stability of all of these other efforts around the specifications and the Cypress tool, the same folks within my organization that would really need to participate in all these multiple efforts of the measure developers in developing new measures are also today heads down still trying to address new versions of measures. We got, as many of you may know, we got new versions of measures for the hospitals in April and for the physicians in June. And so we're still actually working through that whole process and making sure all of our EHRs are certified to that version. And we're also still getting fixes to some individual measures as well as some Cypress updates that have to be re-implemented and then retested. So we're finding it very challenging, as much as we really want to participate in all these new measure development efforts, to really devote the resources to that effort. So we think that if we can stabilize the whole process and ensure that moving forward we've got a really stable foundation to work from, especially when we go into stage 3, we'll be much more able and have the ability to participate in all of these exciting new areas that we're going into with new measure development.
Thank you. And I think that is one of the big challenges just for the EHR programs in general, is that as with non-electronic measures are updated on a regular basis and new versions come along, typically annually, and I think that presents a particular challenge in the EHR environment. So that is something I think going forward we're going to have to collaborate together to figure out how to get more nimble and flexible on that realm as well. So the next question is for Minette to start off with, but Cynthia, you may want to chime in here as well. So we've made a number of changes, as we've described already, to the eCQM lifecycle, including a greater focus on de novo measures, beginning measure development and review sooner, as we've talked about incorporating testing and stakeholder feedback sooner. But from your perspective, Minette, because you're really on the front lines of doing this work and also on the front lines of implementing the lean processes that we've all come up with together, what additional steps do you think might be beneficial to further streamline the process and to produce higher quality and measures in a more efficient fashion?
I think, and that is also the panel that had briefly presented to had raised a lot of those issues. So I think first and foremost was the key to the lean process is communication. And so that is between all the different stakeholders, internal and external to CMS. So take, for example, public comment. So during the life cycle of an eCQM, there is a part where we do put out for public comment, the measure, and it's not in its entirety. It's not yet e-specified, but it does have enough information, like numerator, denominator, that would give you a good clue as to what that measure is intending to measure. So right now, we have that piece. As Cindy had said, we had just closed on 2 measures. But what we would like is we would like early feedback to those measures, as opposed to waiting until the NPRM, because I think also that's where we get a lot of comments, is when we put out the NPRM. So it would really be helpful, I think, to all of us, really, if we can get that public comment earlier on. And it'll be at different stages of the measure development cycle. Maybe later on we might put it out when there are more specifications to the measure. But for right now, I think engaging the provider community as well as we develop is really going to be key.
Did you want to tack on? Yeah, getting engagement from as many stakeholders as possible early on in the process. We're seeing a significant contribution to our measure development activities. The vendor involvement has been fantastic. As we move a little bit farther into our testing, we're going to be approaching providers and working directly with them, and that is only going to improve the quality of the measure. I did want to make a distinction between the testing that we're talking about here, the measure testing versus the implementation testing. Mm-hmm. My focus as a measure developer is to make sure that it's a good measure, and we have technical folks who help us with the technical specifications to get it towards implementation. But it's very helpful for us to hear the implementation challenges so that we can think about that as we develop the next round of measures.
Great, thank you. And my next question is for Dr. Bloom. So going hand in hand with efficient and high quality measures is the relevance of the measures. So at CMS, we made very concerted efforts to address relevancy in the 2014 menu of eCQMs. We went from 33 measures in stage 1 to 64 measures in stage 2. So from your perspective, were we successful at putting out relevant measures? Did we do just an okay job, or did we completely miss the mark? And then how can we further expand the pool of relevant eCQMs to apply to the very large variety of providers that are out there?
So I think that the focus on having relevant measures is absolutely critical. And the measures that have been developed, many of them are very relevant and very applicable to measuring quality across a multi-specialty practice and a hospital practice. I do want to back up just a little bit to comment on the implementation challenges. As you have a great measure and you have a beautiful tool that's developed to help to implement that measure. That really, to me, is just the beginning of the whole process, because then you have to take that beautiful tool, which many of our electronic medical records have just gorgeous, beautiful tools, but then you have to implement that into your workflows. And doing that is a challenge with our team-based workflows that we have nowadays that have processes both inside the office and inside the hospital and outside our offices and hospitals as well. And so developing the team and the system of care to implement those to the point where we can measure them, I think is critical. And so as you're developing these workflows, even though Geisinger has a large amount of rapid cycle redesign that we do within our organization, there is not just the CMS measures that we're focused on, but there are other health plan measures, there are other programs, there are other state medical assistance programs, as well as all the other work that we're doing around redesign. So the sheer number of measures that are available, even though they all may be relevant or have some relevancy, becomes a challenge to an organization as well. And so that understanding where an organization is and having relevant measures for every stage of their organizational development, I think, is critical, because the even before this, in the last talk, they talked a lot about the workflow redesign that's necessary to do this. And it's really all about that. It's about the workflow redesign that goes along with the tool to get the measure that's necessary. And that takes time.
Yep. Even more reason to get providers involved up front, early and often. It's for that exact reason. So finally, I want to ask each of you about what the ideal state would be for electronic clinical quality measures, both for identifying appropriate measures, in the development of measures, or in the implementation, however you wish to think about it, and tell us what your vision is for if you had a perfect world, if we could jump to that perfect world right now, what would that look like to you? So why don't we start with Minette?
Okay. So I think probably the most important is to bridge the gap between the requirements and the ones who have to implement the requirements. And again, as we had also learned from the earlier panel discussion, that's huge. But also more importantly, that would ensure and certainly let CMS know that the measures that we are selecting are truly making a difference in providing healthcare.
From the measure development perspective, our ideal state would be ready access to data that would and also partnerships with both vendors and providers so that we'd be able to have access to the data and the clinical practices and understanding so that we could improve the quality of care delivered and the outcomes for the patients.
Okay. Jenny?
So I think that I absolutely agree with both what Cindy and Minette said. I think that would help us greatly as well as we're more downstream in the whole process. I think that thinking about future state, if we were able to take a measure and know that we could very quickly consume it into our measure engine without doing a lot of rework, which unfortunately today is the case, that would really help us speed up the time to implement the measures. At the same time, I think some of the work that's ongoing around looking at the data model and thinking about ensuring that most new measures would still use the same data because it's already defined in a data model, and we already could know that data was resident in our EHRs, and including the logic. Measures could actually reuse the same logic when it makes sense. A lot of times today, because measure developers are all working on their own contracts in their own time, and even though a measure may look like it's using the same type of logic to define a denominator, each measure developer may do it differently, which means we have to implement it differently. So the more we can reuse those components and then have that ability to automatically consume that measure specification a lot more easily than we can today, I think will really help us, as Kate said, get to the point where we can more easily address things that need to be updated. We completely understand that evidence changes, and there are reasons why we need to update measures more frequently than program updates such as meaningful use may require. But today it's such a burden on everybody to actually implement that new measure, and then for the provider to actually then implement it in their software and do all the training and the workflow analysis that they have to do, that it becomes very difficult. And so I think our ideal state would move towards the point where we could easily address updates that are needed to be done without having as much time and burden put upon, especially our customers, because that ultimately it's really all about helping our customers improve the quality of care for their patients.
Great, thank you.
Okay, well, I agree with everything that everyone has said so far. And I would just add that we've talked a lot about, many, many measures. So, and I know there's work to align. So getting to a set of consistent measures that are acknowledged as, real measures of quality that share these consistent concepts, I would say, as Ginny said, that if you look at them together and evaluate them together, and that they are linked to the way clinical care is practiced and delivered, so concepts are linked to the way the clinicians actually do their work, so that when they're delivered, the implementation is, as to meet the goal, not a burden on the providers. It's a part of their workflow, it's consistent, and that they can implement them and feel, good about the products they're using to help them do that, and to meet the ultimate goals of improved quality. That would be my goal for end state.
And I agree, that's very well said. I think the ideal measure would be one that really is an ECQM that doesn't require any manual chart review, that's captured discreetly in the electronic medical record, that's captured as a part of the standard workflow, that doesn't require somebody's individual memory to go to that field to put it in. It's a part of the standard workflow that's done. But also, in the ideal world, would capture that information that's done outside your organization in some way, capture those immunizations and visits and tests and procedures that are done, outside of your own electronic medical record, and then even going further along, making sure that as that is reported, that there are national benchmarks that are widely distributed that give people ideas of opportunities for improvement, and to give them a chance to budget and plan for their quality improvement activities throughout the year.
Great, thank you. Just to paraphrase, Dr. Carolyn Clancy, the former director of ARC, she used to always say that the ideal state was that you hit F7 and all the measures come to CMS. And then we're done. Yeah, exactly. Well, ideal state, you're supposed to think outside the box, right? So, so I think, a couple of major themes from what I've been hearing today is that there were a lot of challenges across the spectrum from, I think, for those of us working here at CMS and developing the measures through implementation and the provider's use of the measures, that we're starting to really make some headway on, in part through more frequent and early collaboration and communication with all of our stakeholders. And I want to assure you that at CMS we're very committed to continuing that, because we're also really starting to see the fruits of that labor. So we welcome your feedback for how we can do that even better. And with the ideal state that you've all described, I think that is where we want to get. I completely agree with what everybody said. We definitely have these regulatory cycles and statutory deadlines, and there's a really push for rapid implementation and adoption of health IT. And I would just give anybody who wants it a final word to be able to say to us, what else would you ask of CMS? What else would you like for us to be doing that maybe we aren't doing or we could be doing better as we move forward into stage 3? You've talked about a lot already, but I'll give you a last word if there's anything else any other advice you'd like to give us.
I would just say, and we met recently to talk about it, as I said when we first started, I think dropping back and getting all the stakeholders at the same table, and I know there's issues with committees and work groups and whatever it is, a meeting, to sit and look at some of these issues and really kind of maybe look at some of the root causes with the providers, with the measure developers, the vendors, and CMS and ONC at the table as we consider such a fundamental shift. It's hard to have those, deep, hard discussions through a rulemaking process or something like that. So to step back early together and try and get to the root of some of these problems, we would welcome the opportunity. I think it would be a good way to get to some of the root causes.
I think there's a tremendous amount of work that goes into developing these measures, and a tremendous amount of effort of provider organizations when they start to work with Mathematica and others on developing these. And so providing incentives for organizations in these early stages to help to develop the measures and work out all of the kinks as it goes along, I think would be very valuable as well.
Thank you. I think we actually have a little bit of extra time, so I wanted to actually open it up to the audience to see if anybody has any questions for our panelists. And you can either come up to the microphone. That's probably the easiest, just come up to the microphone. Or I can hand you a microphone. And please introduce yourself and where you're from before you ask your question.
Sure, thank you. I'm Walter Suarez. I'm with Kaiser Permanente. I'm also actually co-chair of the HL7 work group that is developing the standards for clinical quality information reporting. And my question was about that. What is your perspective on the electronic standards that are being developed to report these measures? For example, HQRM, QRDA, the kind of standard, you focus significantly on the measure development itself and the measure content and the definition of measures and testing of the actual measures. But on the other end, it's really the structure that is used to pull out the data from the EHR and report it electronically. And that's what this work group is doing. So I wanted to hear your perspectives.
Sure. So as measures are developed for CMS under contracts for CMS programs, we actually use the measure authoring tool. And that is an electronic tool, and within that is the quality data model. And the output of using the tool, so measures go, I mean, developers go in there and actually author their measures using this MAT. And the output of the MAT tool is now your machine readable and your human readable format using the HQMF. And then starting in 2015 for the 2014 Stage 2 program, CMS is actually going to start accepting data, and so we're accepting it either QRDA1 or QRDA3.
And can, for folks who may not know the difference between QRDA1 and QRDA3, would you like to?
Sure. So QRDA1 is at the patient level. So we get all the information on just one patient, and this is very high elementary kind of definition. And for QRDA3, providers aggregate their data and send it in as one file. Did I do that well? Thank you.
Hi, Charlene Underwood from Siemens, and I participated on several of the work groups early on in the measure development process. So again, this I know has been a long process to get us to where we are today, so thanks for having this panel. I have two comments. One of the areas, and these are just kind of suggestions, thinking about this for many years. Again, when we talk about measure reporting, I think the point here is quality. So we're not talking really about reporting. We should be talking about quality. So in that context, I know that there's a lot of initiatives around how we can link clinical decision support and align that with this program. So I would hope that would be, considered as you're thinking through what is that perfect state. The other state is I had an opportunity yesterday to listen to one of your participants in the post-acute care area at CMS. And they have done some model work in terms of what that future state of model development, of measure development could look like, and I think you should consider that. And that future state starts with looking at the data elements. And they've looked at the data elements and they've said, okay, these data elements are the data collected from multiple settings. They've looked at how to make them uniform. They've looked at how to make them standardized. And the value to that is the issue that you raised relative to, okay, I collect goals in this way and I collect goals in that way. Ultimately, we need to start to collect vital signs in a common way. So at the end of the day, it's going to be the data that we collect, and you're going to ask us as vendors and the providers to start to ask it consistently. So take a look at their model. They started with the data. They made it uniform. They looked at it in terms of reliability, all important things. And now that data is being used to develop measures around function, because they found that function is one of the determinants of cost in those kinds of settings. And then they're evolving measures in the 6 domains of the MAP program. So they're aligned with your program. But think about that, because it does start with the data that we're collecting. And the more we can work toward that uniform set of data that can be collected, it gives us a platform to be more agile and more responsive to the demands of the program. Thank you.
Anybody have a response or to that? I would like to actually ask Dr. Bloom, maybe in your health system, you mentioned clinical decision support. Can you talk a little bit about are you using clinical decision support in conjunction with your reporting electronic clinical quality measures, or even just other quality measures?
So certainly we use clinical decision, and there's different uses of clinical decision or types of clinical decision support, from simple aggregations in health maintenance fields to more active alerts and reminders, to very sophisticated analytics that fire in specific circumstances. And many times we use this accurate clinical information to assess how well we're doing with our care process and our redesign efforts. And so as we think about a new measure, we think about our workflow, we oftentimes in our organization make the clinical case for the relevance, as you said, for the measure. We try to come up with an idea of our current performance. We show our providers that to generate some interest in improving performance. Then we develop some clinical decision support that can help them to improve performance, and then we do reporting that goes along with that. So I think it's an important part of that whole clinical redesign.
Yeah, go ahead. Good afternoon. Tracy Holland. I'm the Director of Clinical Informatics at Michigan State University. I wanted to echo Mickey's early comment a minute ago about finding the root cause of some of the challenges of implementing these measures. And I would challenge you to look to what the vendors and what some of us at the eligible provider level are using in our own development cycles, and that's obvious. I think the agile development methodology and getting people and getting across the spectrum input very, very early in the process so you can identify what those are. And I heard even the last speaker use the word agile. We need to speed up for everyone. Thanks.
Great, thank you.
Hi, thank you. Diane Jones, American Hospital Association. I'm really struck by comments that Mickey and Jenny shared in terms of their particular challenges with testing as you're trying to develop in software. But I would just urge folks to also keep in mind that even after you've had some testing with respect to the development stage and testing with respect to as you're trying to develop your product, there also needs to be testing in the actual clinical setting. Our members have shared with us, and we've shared with many of you, their experience relative to stage 1. I'm more than a little concerned that we're still working through challenges with stage 2 measures. And of course, for hospitals, stage 2 started October 1. Perhaps that's why there's a challenge in terms of certified product in the chapel. We don't know yet. So even as we're thinking about how to make things lean and agile and taking out waste and so forth, there still is a appropriate amount of time required, even after you've gone through your steps, when the product comes to the hospital, to ensure that the actual technology will work as they expect it to. It's something to keep in mind.
Thank you very much. Any other questions? Okay. Well, thank you all for joining our panel today. I believe we're going to have some closing remarks in just a moment from Rob Anthony, so I will turn it over to you, Rob.
There are few spots that are more coveted than the last speaker on a Friday afternoon as you're all trying to go home. So I'm going to make this really quick. I just want to thank everybody that participated, MedCai, HIMSS, AHIMA, MGMA, WEDI, EHRA, and all of the vendors who were here, GE, McKesson, Siemens, all of the representatives of providers and provider organizations. Thank all of you who came out for this. We have had a couple of questions about whether slides and recordings will be available, and they will be posted to the eHealth website, and they will be there. For folks who are actually here, the question keeps coming up about what happens with this. What do these discussions generate? What is next? And I think the very broad answer is probably more of this. What we're really talking about when we talk about the issues in quality management and innovation models and HIEs, both noun and verb, and certainly stage 3 are a number of ongoing issues and conversations that need to continue much more in depth than we are able to do an hour at a time. And we certainly recognize that, but we value the contributions that people make and bring to this. We value the voices that are involved. And so for those of you who are in the room, you are going to receive a survey by email that asks for not only you to rate these events, but also to give us some feedback about what might be useful to cover in the future. For those of you who have joined us by via web, we welcome your suggestions and input as well. And with that, safe travels, and thank you all for making the journey.